Hello, this is the video for menstruation disorders. What we're going to do during this video is briefly go through 5 different disease states that are considered part of menstruation disorders, and then during class we will review some of this material as well as do 2 different cases. So similar to the contraception packet and workbook, there are instructions on UB Learns, the cases workbook, and some additional readings. Similar to contraception, the testable material is going to be the information in this video as well as the packet and cases workbook. There is a folder with additional reading on menstruation disorders, and there's additional readings in your book if you wish to know more information about any of the topics we talk about. So if you could just pull up the menstruation disorders packet, we're just going to start in the beginning. It has the objectives. These are the same ones that are listed on UB Learns. And again, this could be used as a study guide for the exam. So if you're able to identify which disease state the female is presenting with based on their signs and symptoms, and recommend an appropriate pharmacologic or non-pharmacologic treatment plan based on whatever disease state they're presenting with, then you should be able to answer most of the exam questions related to this topic. So the first of the 5 is amenorrhea. So it's important to remember what the definitions are. There's primary and secondary amenorrhea. Amenorrhea is basically the absence of menstruation or menses. Primary is considered the absence of menses by age 15 and the presence of normal sexual development otherwise. And then secondary is the absence of menses for 3 cycles for 6 months in a previously menstruating woman. So primary is usually a younger patient, secondary is usually an older patient. Sometimes they can present with other symptoms, and this can be related to the cause of amenorrhea. Usually patients aren't in acute distress, otherwise they're just thinking that they might be pregnant. So unrecognized pregnancy is really the most common cause. So we'll talk about in class how you can evaluate for pregnancy and the different tests that are available, especially with the case that is associated with amenorrhea. But there are some laboratory tests, including pregnancy tests, and then some other tests for things that can cause amenorrhea, like hypothyroidism, hyperprolactinemia, PCOS, and other gynecologic disorders. So the pathophysiology really depends on the cause, so we won't go into that too in depth, but we'll just focus on the treatment. So if the patient is looking to have menses or looking to have improved fertility because of amenorrhea, then there are a couple different options based on the cause. So based on the cause, you should know what the general drug class is for management. So for example, if the patient is suffering from anorexia or an excessive exerciser, someone that is a marathon runner, or during different sports seasons they have experienced amenorrhea, then weight gain is really the biggest thing that you're going to counsel the patient on, decreasing the level of exercise. And then whether or not that's effective will lead you to other options. For hyperprolactinemia, the thing that we will prescribe for a patient is a dopamine agonist, such as bromocriptine. And then if they are having anovulation secondary to PCOS, we'll talk about PCOS as a disorder in the infertility section. The first question you should ask the patient is whether or not they want to be pregnant, and then based on their answer, it can lead you to different medications. And then for an unknown cause of amenorrhea, we can provide a progestin, which will induce a withdrawal bleed. So estrogens and progestins are going to be used for a lot of these different disorders of menstruation, either in the form of combined hormonal contraceptives or as progestins alone. So it's important to remember their role in the menstrual cycle. Estrogen stimulates endometrial growth in the follicular phase, so the endometrium starts to develop while the follicles are developing. And then as we move in to the latter half of the menses cycle, progesterone is the dominant hormone, and it causes endometrial organization, which will create a hospitable environment for implantation. So we can use these hormones to our advantage if we want to induce a period. So for non-pharmacologic management as a whole, weight gain is something that can usually help, especially if patients are anorexic or excessive exercisers and have lost their period as a result of that. And then additionally, calcium and vitamin D is usually recommended regardless of the cause of amenorrhea. So this can be another non-pharmacologic recommendation that you make. Okay, moving right along to menorrhagia. Signs and symptoms of this disease state is a heavy period, so patients will complain of a heavy or prolonged menstrual flow. Sometimes they'll have additional symptoms related to blood loss, such as fatigue, pallor, or lightheadedness, and sometimes they'll have dysmenorrhea or a difficult or painful period in combination with it. There's a couple different causes, and basically, depending on the cause, they will lead to alterations in the endometrium, which can change uterine contractility, and additionally, sometimes platelet function or coagulation factors will be impaired as well. The biggest thing for treatment of menorrhagia or a heavy menstrual flow is initiating NSAIDs. NSAIDs can decrease blood loss by up to maybe 75% in some women and usually up to 50%. So just initiating NSAIDs, an over-the-counter option, is our first-line treatment. There are surgical things that can be recommended for patients based on the cause. So sometimes endometrial ablation or something so drastic as a hysterectomy can be used if the patient is really suffering from extreme menorrhagia or heavy menstrual bleeding that is resulting in anemia. But then the other pharmacologic options we have are oral contraceptives, either as a combined hormonal contraceptive or progestin-only pill, or as a progestin IUD. Progestin IUDs are extremely effective in these patients if we remember that medications such as Mirena can reduce menstrual blood flow by up to 90%. So this can be extremely effective in patients. The third disorder is anovulatory bleeding. This can also be referred to as abnormal uterine bleeding with ovulatory dysfunction, or AUB with OD. The signs and symptoms of this anovulatory bleeding are irregular, heavy, or prolonged bleeding, so it's kind of a non-regulated menstrual cycle. It can range from spotting to a heavy menstrual flow. Sometimes it's associated during the perimenopausal period, so once patients are moving into menopause, they might have abnormal uterine bleeding or non-regular bleeding. And sometimes there are other symptoms associated with it as well, especially if the patient has PCOS, they might present with acne, hirsutism, or obesity. Laboratory tests can be done to evaluate the cause of the anovulatory bleeding, and usually it's either to test for PCOS or to see if the patient is hypothyroidism or if they have perimenopause. So the pathophysiology for anovulatory bleeding is kind of important when it comes to thinking about the medications. So due to ovulatory dysfunction, the corpus luteum is not formed, so in the second half of the cycle. Then the ovary does not secrete progesterone, so thus the endometrium grows due to estrogen but doesn't differentiate due to that progesterone production. So without the progesterone, there's no endometrial differentiation and you have unopposed estrogen. So it grows and becomes more vascular and fragile and is very prone to bleeding. So bleeding at times than it normally wouldn't. So you will have non-cyclic bleeding, and sometimes this can even lead to a precancerous state such as endometrial cancer because of that unopposed estrogen. So depending on the cause, either PCOS, menopause, thyroid disorders, you can choose different agents. Again, NSAIDs will help to decrease blood flow and can be added onto therapy. Some non-pharmacologic recommendations, especially if it's due to PCOS, can be weight loss to improve regularity, ovarian function, decrease hirsutism, and improve therapy, such as fertility therapy. Other non-pharmacologic recommendations can depend on the cause, so there's non-pharmacologic recommendations for menopause management or hypothyroidism. Then we can use, again, combined hormonal contraceptives. The estrogens given in a continuous fashion promote endometrial growth and stabilization, and then they'll prevent the anovulatory bleeding. Especially if the patient has PCOS, CHC that has drospirenone in it can be used, especially for its for the androgenic symptoms. It's anti-androgenic because it's similar to spironolactone. We can also use medroxyprogesterone acetate, so this comes as an oral tablet or it can be in the form of Depo-Provera in the injectable. And this kind of suppresses our pituitary gonadotropins, leading to decreases in estrogen and progesterone and preventing anovulatory bleeding. Then we can also use some estrogen modulators, which are usually used for fertility, clomiphene, and letrozole. This is used if the goal for the patient is to induce ovulation. We'll talk about these agents more when we get to infertility. Fourth is dysmenorrhea. This is when patients are complaining of a difficult or painful period. So it can be, again, either primary or secondary. So primary is when they complain of these symptoms with normal pelvic anatomy, and secondary is if they have something else going on, some abnormal thing, pelvic inflammatory disease, endometriosis, cysts, tumors, fibroids, anything that could be causing pain and cramping. The pain and crampy feeling usually begins before or at the onset of menses and lasts for about 1 to 3 days, depending on the patient. Non-pharmacologic treatment is listed there. It's related to, managing it over-the-counter, rest, heat specifically, wearing loose clothing so that the constricted area doesn't hurt. Smoking cessation has been shown to improve symptoms, and then also increasing exercise has been shown to improve symptoms. Again, NSAIDs can be used, especially if the patient is having worse blood loss with the dysmenorrhea. And then, similar to a lot of our different therapies, combined hormonal contraceptives can inhibit proliferation of endometrial tissue. Because the pathophysiology, I'll just backtrack for a second. There's a release of arachidonic acid into menstrual fluid, which increases prostaglandins, and prostaglandins cause uterine contractions, which can cause the cramping and difficult or painful period. So this stimulates pain fibers and reduces uterine blood flow, causing uterine hypoxia, which is also painful. So anything we can do to add on to decrease prostaglandins and decrease these uterine contractions will be helpful. So NSAIDs, because of their mechanism, will help with this. And then combined hormonal contraceptives will prevent proliferation of endometrial tissue, thus decreasing endometrial-derived prostaglandins. And then progestins, either as Depo-Provera or a levonorgestrel IOG, will again prevent organization of endometrial tissues, decreasing prostaglandins. Okay, the final disorder is PMS or PMDD. You might have learned a little bit about PMS in self-care, so we'll focus mostly on PMDD. PMDD is a more complex form of PMS, and the important thing to note is that you have to have at least 5 of the symptoms, either mood or physical symptoms, and 1 must be markedly depressed mood, anxiety, irritability, or affective, or labile affect. The symptoms have to significantly interfere with your life and not be the result of another psychiatric disorder. So patients may or may not present with acute distress. Similar to self-care, there's non-pharmacologic management based on what symptoms they're complaining of. An improved diet that's low in carbs and sugar and alcohol and caffeine can help with symptoms of PMS or PMDD. Increasing exercise and using cognitive behavioral techniques such as de-stressing techniques are helpful. And then for pharmacologic management, in addition to NSAIDs and diuretics for pain and bloating, you can also use SSRIs. These can either be used continuously or just during the luteal phase of the menstrual cycle. These are the ones that are approved, and all of these can be used except for paroxetine in patients of childbearing age, secondarily to the birth defects associated with it in patients that are of childbearing age. So SNRIs, venlafaxine has been used, and then finally, combined hormonal contraceptives have also been used to provide a continuous level of hormones because fluctuations in hormones have been linked to alterations in neurotransmitters such as serotonin. So providing a continuous amount will help with symptoms. That concludes this video.